So Matt and Shannon, I want to pivot here to the other really most important abstract. I would say at ASCO, the number one and number two, I'm not sure one is better than the other, but that SOLO2 overall survival, and maybe it's not the most important because it's not going to change practice. But let's get into the secondary debulking conversation. There was a study published in the New England Journal that many of our listeners may have participated in. It's called GOG 213 that showed that a second operation wasn't helpful. Tell us about that study, Matt. Published in the New England Journal, GOG 213.
We talked a little bit about 213 just a bit ago when we were talking about chemo selection. So this was a little bit complicated because there was both like a chemo question and a surgical question that was asked. And I think part of the reason Rob Coleman has gray hair is mostly this trial. So 485 patients randomized. 67% of them had complete gross resection. Follow-up was good for the trial. Most of these patients had bevacizumab, which really is the difference from the other trial. 84% of the patients had bevacizumab. Hazard ratio actually favored the group that you didn't operate on, 1.3. And a year longer if you didn't operate on them from an OS standpoint. So we really scratched our head after this trial came out. Now, there was definitely some patient selection who ended up being part of the randomization. Surgical morbidity was about what we expected. So we anxiously awaited desktop 3. And I think, I believe Shannon's going to tell us about that.
Yeah, it's interesting. I always say it takes 2 studies to convince anyone of anything. I don't know why you guys have adopted the LAC trial with 1 study. The LAC trial, which is a cervical cancer trial that showed that if you have radical hysterectomy open, that you live longer than if it was, minimally invasive. But GOG 213 didn't change practice. It changed sort of opinions a little bit. So the confirmatory trial, the second trial, was supposed to be desktop 3, and it was presented at ASCO. Did it confirm or refute GOG 213? Shannon, tell us.
Well, it's a little complicated, right? So
yeah, it did both.
It did a little bit of both, right? So it was a really nicely designed study, and I think to Matt's point, they were a little bit more strict around the selection of the patients, and so they used their AGO model that they had previously validated in other studies that includes looking at ECOG performance status. Were they able to get to no gross residual disease after surgery the first time, and did they have ascites at recurrence? And they randomized patients based on if they met these criteria to either secondary cytoreduction or going directly to chemotherapy. And they all got platinum-based chemotherapy. There was really no mandate to include any other targeted therapies. And in this study, about 22 to 23% of patients on each arm did receive bevacizumab. So there was only a smaller population that had the chemotherapy with that drug, which we know can be a great equalizer between groups. And what they found was a significant difference in progression-free survival, which was one of the co-primary endpoints. And we all thought, well, that's great. The tumor's been resected, so of course it's going to take longer for you to see something and progress. What we really want to see is overall survival. And that's what they presented at ASCO this year and demonstrated a statistically significant and clinically significant difference in overall survival with a reduction in the risk of death of about 25%, a hazard ratio of 0.75, that yielded about a 7-month difference in overall survival. But when they teased out the patient populations, that's where things got really interesting. The patients that were able to achieve, that the surgeon was able to achieve a no gross residual did by far the best. I think the median was somewhere around 62 months that those patients.
213 showed that too. That could be biology, not the science of the knife.
That's right. But when you looked at the population that got surgery and did have residual disease, they did worse than the chemo alone arm. So for me, this again told me, gosh, we need to do a better job of knowing how to select these patients. I know you guys, the surgeons here, we all have patients in our practice that we did secondary cytoreduction on that lived another 6 or 7 years, and we high five ourselves, but you're right, it's the biology. And I think we need to do a better job of selecting them. For me, this says that, yeah, there is a population that we should not operate on. And there's a population that potentially can really benefit from surgery. Where bevacizumab adds into that, does that just kind of negate the surgery? And if you're going to give bevacizumab, then, it doesn't matter. I don't know. I think we're still trying to understand it. The other abstract that was presented at ASCO, the SOC1 trial, which was a study that had a similar population, they did a little bit different selection. They had a score that they utilized called the I model that, incorporates things like stage. Did they have a primary cyto, were they able to get R0 after their primary cytoreduction, what the CA-125 level is, ascites. Now that group, they did not demonstrate a benefit in overall survival. So we saw, again, progression-free survival benefit to the patient population that got surgery, but they did not demonstrate a statistically significant difference in overall survival in that group. Still early, but again, a little bit confusing. But when you look at the curves, it's the same thing. The population that can get that R0, they benefit. The population that gets surgery but does not get to no gross residual disease, they look worse than the population that gets chemotherapy.
But in 213, the no surgery did better than the R0.